Thank you all for joining us tonight. It's great to have you here with us. And as you see, we have all these fancy lights set up, and we're recording this in a very professional looking way. So we're excited to have you here with us, and we really look forward to a great event. I'm Barbara Bass. For those I haven't met before, it's really my great pleasure to serve as the Vice President for Health Affairs and the Dean of the George Washington University School of Medicine and Health Sciences. And tonight I'm welcoming you to one of our Bicentennial Faculty Lectures in our series of 4 that we're celebrating over this 12 months of our bicentennial. Today we're featuring our colleagues, Dr. Jill Catalanotti and Dr. Sumitha Raman. And as you know, these lectures were selected in a competitive way, and I got to tell you, they had a fabulous proposal. So we are so thankful for you for having submitted that, and we really look forward to your talk. But before I formally introduce them, I want to, especially for those on the recording that maybe didn't see all of these, but I want to note that this is part of our bicentennial series, and we are, this GW School of Medicine and Health Sciences, celebrating our bicentennial this year. The university, as you may recall, celebrated its bicentennial 3 years ago, 2021, when it was founded in 1821. And medicine, while a part of that original charter, actually didn't get up and running for another 3 years. And it was founded then in 1824. So now, for 200 years, we've been at it, doing our stuff. We've been training doctors, we've been training talented, compassionate physicians for now those full 200 years. And in more recent decades, as you may know, starting about 50, 60 years ago, we started training other healthcare professionals, including physician assistants, physical therapy, occupational therapy programs, including our new Doctorate of Occupational Therapy, which just launched this year, as well, of course, the incredibly distinguished scientists that we have in our basic science departments and our PhD students, master's and PhD students in the biomedical sciences across many different areas of expertise. In this Bicentennial Faculty Lecture Series, it's the start of a new speaker series that we really will continue in the years to come, because it is really kind of fun for us to highlight the great talent and expertise that we have among our own faculty. Lots of times our students get to hear them, and sometimes our residents get to hear them, and sometimes other faculty, but this is a way for us to really share that deep expertise with all in our academic medical community. Tonight, we're going to talk about something that is a very compelling and, still very difficult challenge in our community, addressing opioid use disorder at GW and in DC. And as you'll hear, this is not only a scholarly talk, but also one that is laced full of practical application, that applied applied clinical public health that we are so proud to have as part of our programs here at GW SMHS. As I mentioned, a call for proposals was put out back in the summertime. We have 4 of these lectures, and we will have 2 more to come shortly. But first, let's go to the speakers that we have here tonight. Dr. Jill Catalanotti, I suspect, is known at least quite well to everybody in this room here tonight. She currently serves as our Associate Dean for Clinical Public Health and Population Health Practice at GW. At our school, and she is an internal medicine primary care physician. She holds the rank of Professor of Medicine and of Health Policy and Management. Her co-speaker is Dr. Sumitha Raman, who is also an internal medicine primary care physician and assistant professor of medicine at GW School of Medicine and Health Sciences, who joined us, I learned tonight, just 2 years ago after completing her training at Yale University. Over this last couple of years, Dr. Catalanotti and Raman have really spearheaded multiple efforts for the care of patients with opioid use disorder in our healthcare system, but also with broader impact throughout the city. Together, they drafted the GW policy for screening and treatment of opioid use disorder, and Sumitha was recently selected for a GW School of Medicine Health Services research grant to integrate that policy into patient care, with subsequent expansion to our other sites throughout the city, including our Cedar Hill Regional Medical Center, when it comes online later in 2025. In addition to this scholarly work and educational work, Dr. Raman and Catalanotti founded and staff a telephone support line through which they provide real-time guidance to clinicians caring for patients with opioid use disorder hospitalized at GW. They lead most of the teaching here at SMHS in the broad area of opioid use disorder, and we're very grateful to have that expertise. Right now, for example, they're revamping the addiction medicine curriculum for internal medicine residents, and they've given multiple talks across the school, including the departments of surgery, emergency medicine, nursing and case management, as well as, of course, for our medical students. They are currently investigators on a multi-site NIH-funded trial to improve the continuum of care for patients hospitalized with infectious complications of intravenous drug use, the CHOICE STAR study, and Dr. Catalanotti serves as the co-principal investigator for that important work. So, with that background, I'm sure that their lecture, which they have entitled From Crisis to Care, Addressing Opioid Use Disorder at GW in DC, will be really informative, and I really look forward to having the chance to learn a lot tonight. And now, as we get ready to bring them to the stage, first we're going to give them their honors, their awards. So if I'd ask you both to step forward, I'll get you your So with that, let's go ahead and start the program, and I believe you are both going to come to the podium. Is that correct? Thank you.
Yes. Thank you so much, Dean Bass, and thank you all for being here. Dr. Catalanotti and I are so excited to share our work with you. All right, so I'm going to go ahead and get right to it. 110,000 people died in the US of a drug overdose in 2023, more than the number from car accidents and gun violence combined. DC has been hit particularly hard by this crisis. In the last couple of years, DC has had one of the highest rates of drug overdoses per 100,000 residents compared to the rest of the country. The majority of these overdoses are due to opioids, and opioid overdoses specifically in DC have also had a sharp rise in the last couple of years. So what are the circumstances surrounding opioid overdose deaths in DC? Well, we know for one that the people in DC that are affected most by this crisis are older Black men, predominantly living in Wards 7 and 8. We will talk a little bit more in just a second about some of the racial disparities that underlie the opioid crisis generally and lead to a disproportionate rate of deaths among older Black men in DC compared to the rest of the population. We know that Wards 7 and 8 in Southeast DC are some of our least economically advantaged wards and where access to healthcare is already a big barrier for many of our residents. And that definitely plays into this. So what else do we know? Well, while we talk about dying from overdose deaths, right, we know that one way to keep death from happening is to reverse the overdose. And one way to reverse overdose is by using the overdose reversal agent, Narcan or naloxone, that many of you have probably heard of. So in the last couple of years, through the Live Long DC initiative, DC has really been making a concerted effort to get Narcan to the communities across the city that need it the most. And we have reversed a lot of overdoses using Narcan. But it's important to recognize that while that's great progress, it's not enough, right? So for one, we know that the drug supply is rapidly changing. So I told you that most of the drug overdose deaths in DC are related to opioids, and we know that much of that is due to fentanyl, which is an extremely potent opioid, 50 to 100 times more potent than heroin. But we know that recently our drug supply has been contaminated by other things. So people who are using stimulants, right, they're using cocaine or methamphetamine, their drugs have fentanyl in them, they're naive to opioids, they overdose and they die. You might have heard of something called xylazine or tranq that has been in the drug supply recently. Some of these kind of adulterants have made it harder to reverse opioid overdoses by using just Narcan or naloxone. And then the other thing is, while it's really great to be looking kind of downstream and saying, all right, we have an overdose, let's reverse it, we should really be looking upstream, right? Like, how do we keep people from getting to that point to begin with? And we know that in DC, the majority of patients who die of opioid overdoses are not engaged in any form of treatment. So in 2023, more than 50% of patients who had a fatal overdose from opioids had not had any form of treatment in the preceding year, and that includes medications to treat their opioid use disorder. And this is despite the fact that we have multiple medications that have been FDA approved to treat opioid use disorder. And these medications, particularly buprenorphine and methadone, are extremely effective. So we know from research that patients who are engaged in treatment with buprenorphine or methadone have more than 50% less of a likelihood of dying from their opioid use disorder. And I just want to point out that this reduction in mortality is so significant. It's much higher than reductions in mortality that we see from medications that we use all the time in our practice, in primary care and medicine, like aspirin after a heart attack, which we consider to be a life-saving medication, and we really give everyone, right? And if keeping people from dying, reducing mortality wasn't good enough, well, these medications do a lot more than just that. They really help people achieve stability in their lives, get back to lives as normal, right? So these medications have been shown to decrease illicit opioid use, to increase retention in treatment, to keep people from contracting HIV and hepatitis C and other infections, to improve occupational stability, give people more jobs, decrease criminal activity, to improve birth outcomes of infants who are born to mothers that use. The list really does go on. And yet we know that between the time when a person develops opioid use disorder and they get medications for it, if they get medications for it, there could be almost a delay of up to 7 years. This is based on this report that was published in 2019 by the National Academy of Engineering, Sciences, and Medicine. And in this report, they really lay out some of the main barriers to receiving medications for opioid use disorder. And 4 of the barriers that we really consider to be the main ones are stigma toward people with opioid use disorder, as well as medications to treat it, inadequate education of healthcare professionals, fragmentation in our healthcare delivery system, and then legal and regulatory challenges. And Dr. Catalanotti and I are going to focus on the first 2 in our talk, because that's really what our work is generally focused on. The elephant in the room whenever you're talking about treating a patient with opioid use disorder is stigma, right? What is stigma? Well, one definition of stigma is that it is a mark of disgrace associated with a particular circumstance, a quality, or a person. There was this study done in 2016 that used a national survey, and it showed that over 3/4 of the respondents reported viewing people with opioid use disorder as to blame for their opioid use. And a similar, more than 3/4 of respondents characterized people with opioid use disorder as lacking self-discipline. Whenever we think about stigma in this context, it's important to recognize that minoritized communities, African Americans in particular, face significantly more stigma than the rest of the population. And some of this, goes back to our history as it relates to criminalization of drug use. So we have a history in this country of framing addictions of people of color as deserving of criminal punishment rather than worthy of medical treatment. Going back all the way to 1968, the Drug Abuse Act was passed, and it resulted in a similar criminal sentence for possession of 5 grams of crack cocaine, which is the form of cocaine that was predominantly used by Black Americans, compared to possession of 500 grams of powdered cocaine, which was the form of cocaine predominantly used by white Americans. And it really led to mass incarceration of young black men for low-level drug offenses. And over time, that has changed. So in 2010, the Fair Sentencing Act was passed, and that ratio got lower. It went from 1 to 100 to 1 to 18. But there's still an 18-fold difference in the rate at which we criminalize black versus white Americans for a drug offense. So this is important context, right, as we talk about these racial disparities that exist in the opioid crisis. And it shouldn't be of any surprise then that patients might not want to seek treatment, patients who are minoritized especially, because of fear of legal consequences. You know, I wish I could say that the stigma only exists in the general population and in society at large, but unfortunately, it's very much prevalent among healthcare providers as well. There was a large study recently that looked at primary care doctors and their views toward patients with opioid use disorder, and it found that primary care physicians had rates of stigma that were the same or even higher than the general population toward patients specifically with opioid use disorder. And we know that how physicians think about their patients and the words that they use to describe their patients actually matters. This is from research that was done by some of our colleagues at this institution, showing that use of non-stigmatizing language actually improves outcomes in people who inject drugs. And yet, despite that, and despite the fact that opioids remain a leading cause of death in our country, there is a huge lack of education about opioid use disorder among healthcare professionals. In 2020, Dr. Catalanotti was part of this study that looked at program directors of internal medicine residencies across the country, surveyed them, and at that point, less than 12% reported having any form of training in addiction, clinical training related to opioid use disorder in their programs. Since that time, this has become a requirement in internal medicine residencies, and so we know that that number is changing, but we also know from our work that we really haven't made that much progress, and there is a long way still to go. That is a great segue to the second part of our talk, which Dr. Catalanotti is going to deliver, so I'm going to hand it over to her.
And I'll give everyone a moment to read some of these quotes that are on this slide behind me. So I like to share the quotes on this slide with our medical students when we teach them about opioid use disorder. And I'm sure that these quotes resonate more with those in the room who are healthcare providers than those who are not. But for those who are, I think these are really great examples. This was from a paper from Martin and others talking about the lack of understanding and the lack of truly thinking about opioid use disorder as a chronic medical condition that does respond to treatment. And these are just examples of how it just doesn't fit the picture and how physicians clearly don't act that way and really treat this as a chronic medical condition that does respond to treatment in the way that we do other disorders. So it makes us think, why is that? And do physicians and other healthcare providers really have an understanding of the current neurobiological model of addiction? So I don't know about others in the room. This was not the understanding of addiction when I attended medical school, right? We used to view this purely from a psychiatry, psychology perspective, perhaps moral failing perspective, as Dr. Raman mentioned. But we've known now for years that there really is a neurobiological model of addiction. So addiction is known to be actually a chronic medical disease that involves complicated interactions between neurochemical circuits, between genetics, between the environment, and that's widely recognized actually across the globe as an understanding of this illness. So one way that we understand that is some studies that have been done looking at functional MRI, which is what these images are. If you see the brain that's all the way on the left, this is a, quote, normal brain. This is someone who is not chronically using any sort of substances. And for those who aren't used to looking at these sorts of pictures, the red in this image indicates high activity. And so you can see there's a lot of red in the middle portion of the brain on the left side. That is actually a sign of high activity of dopamine. And some of you may have heard of dopamine, right? Dopamine is the chemical that we think of as our reward system in the brain. So for fun, I did an internet search of the word dopamine, and you find pictures like this, right? And that's pretty accurate with our understanding of what dopamine does for us, right? It makes us feel good. It makes us feel rewarded. So I want to call your attention to the image in the middle. This is a functional MRI of a patient who has been chronically using substances. In this case, this patient was using methamphetamines as opposed to opioids, but you can see there's a marked absence of the red in the middle of the brain. So we know that dopaminergic activity, dopamine receptors, are decreased in patients who chronically use substances, including opioids. And that's, a good explanation, right, for why it is that this is a chronic medical disease. We're truly changing the neurochemistry of the brain. So there is reason for hope, and I do want to call your attention to the last picture on the image, the one all the way on the right. This is someone who has been abstinent from use of drugs for 14 months, and you can see the red is starting to come back, right? And so I think that to all of us can feel reassuring, but I would call your attention to 14 months, right? So we should expect in treating this chronic disease to have to support patients for a long time. That would be typical with what's known of the neurochemistry of this disease. Another important thing to think about and to know about is the sort of pharmacology of opioids and how that relates to people's, therefore, behavioral developments with this illness. So 2 important concepts that relate to chronic use of opioids are tolerance and dependence, okay? So tolerance is the idea that as your body becomes used to having a chemical present in it, you need to have a higher and higher dose of that chemical to have the same effect. Okay? And so people will describe having to use higher and higher quantities of opioids in order to attempt to reach the euphoric state that they previously were able to reach when using opioids. And people will say over time they cannot actually reach that state again. Again, over time with chronic use, people become dependent. And so what physical dependence means is that your body is so used to having that chemical present that when it is then not present, you actually experience withdrawal symptoms. And those are true symptoms, and people feel truly sick. And unfortunately, people know the fastest way to resolve those symptoms is to just reintroduce the chemical and to use again. So having this actual understanding of addiction as a chronic disease, as one that has neurochemical underpinnings and makes sense with the pharmacology we know of opioids, is one component that's really required for health provider education to attempt to eliminate stigma and help us to move forward in treating this. Dr. Raman also mentioned in that report from the National Academy of Science, Engineering, and Medicine, another important barrier is the regulatory system that's related to this, right? And frankly, this is really different for healthcare providers. We're not really known for staying up on the law, right? It's not something we're regularly reading about, but regulations are confusing in this area and they change. So one great example of this, some of you may have heard, when buprenorphine first was FDA approved about 20 years ago for the treatment of opioid use disorder, you had to obtain what was called an X waiver, and this meant physicians needed to have 8 hours of specific training about buprenorphine before you could obtain a waiver that was attached to your DEA license and you could prescribe it. And I should say, in addition to those 8 hours required for physicians, PAs and NPs were required to have 24 hours of specific training before they could do this. So not only is that a barrier of time, but additionally, I can't think of any other medication that I'm required to get specific training for. So it automatically creates the belief that this must be something dangerous. This must be something that I can't just do myself. Unfortunately, even though that waiver actually was rescinded in December of 2022, which is great news. So now any physician or any prescriber who has a full DEA license can prescribe buprenorphine, which is one of the medications to treat opioid use disorder. Many people still don't know that's happened, despite that having now been almost 2 years ago, right? So those changes in regulations are hard to stay track of. Another important regulatory area that I'll speak a little less about is methadone. So methadone, being the other main medication used to treat opioid use disorder, is highly regulated. So unlike what I said about buprenorphine, the standard average provider cannot prescribe methadone. It can only be prescribed in opioid treatment programs. However, there are actually caveats to that most people don't know about. So for example, of just a few years ago, it became legal to prescribe methadone in the emergency department. It has become legal to dispense to a patient 3 days worth of methadone to help them bridge their methadone care. But if you ask a standard provider, they don't know that. Right, and don't know they can act on it. So it's a moving target of regulatory things in this arena that we need to try and stay abreast of. So, the question I think about how to re-engage people or how to engage people in the first place in their care is really important. As Dr. Raman said, more than half of the people who died of overdoses in DC were not at all engaged in care for their opioid use disorder. And we know that for the most part, patients who have opioid use disorder try not to interact with the healthcare system, right? They know about the stigma, they know about our lack of education and knowledge, and they're trying really not to come here. But there are some reachable moments, and that is when people can't avoid coming to the healthcare system, specifically when they're hospitalized. So the concept has really emerged across the opioid use disorder world of using hospitalization as a reachable moment, as a time that we can say, we have you here, you're thinking about your health, something has happened perhaps related to your opioid use that is impacting your health, and maybe we can now engage you. And so the Live Long DC initiative, this is actually their #1 goal under treatment in their current strategic plan, is to actually initiate patients on medications for opioid use disorder while they are in the hospital so that we can then transition them to care when they go out. So how are we doing at that, right? How have we been doing at using hospitalizations as a reachable moment? So as Dean Bass mentioned in her introduction, we participated in a study that was NIH funded called the CHOICE study. This was across 4 institutions, so GW University of Maryland, which was the lead site, West Virginia University, and Emory University with Grady Hospital. And we did a chart review looking at 4 years of patients who were admitted to the hospital with an infection, and the presumed or perceived reason for that infection was injection of opioids. And we really just tried to answer the question, did we take advantage of the reachable moment? And if you look at this pie chart on the left, that's all 4 institutions together. So there were over 1,600 patients who met the criteria. You can see 20% of them were actually already on medications for opioid use disorder at admission. But the other 2 pieces of this pie, those were all people who could have been candidates to receive medication for opioid use disorder while with us. And as you can see from that, fewer than half of those people were actually initiated on medications while they were hospitalized. So we in particular wanted to look at the data from GW because I will confess to everyone here, I really enjoy research, and one of my personal motivations for doing research, especially observational research, is to point out where we're behind so that we can catch up, right, to other folks. And so we wanted to say, what does the GW data look like, right, for those particular 4 years? And that's the pie chart that's on the right side of this slide. So out of our patients, you can see actually a higher percent of them were on medication for opioid use disorder before they came into the hospital, and that was actually entirely methadone. 100% of them were methadone, none on buprenorphine. But if you look at the remainder, that measly green pie piece doesn't look so good, right? So we started fewer than 10% of the eligible candidates for medication on opioid use disorder on that while they were hospitalized with us. So, for Dr. Raman and myself, and for other folks we've worked with around our medical center, it really demonstrated we've got our work cut out for us, right? We know we need to focus on hospitalization, and what are we doing there? So over the last, I would say, approximately 3 years, or 2 to 3 years, we've been working on several different initiatives across GW Hospital to see, how can we move all the possible markers that relate to this. So first, I will say the Peer Recovery Coach program, I take no credit for this. I did not in any way start it, but they've been amazing, incredible partners to us, and I want to mention it. So the DC Health, through the DC Hospital Association, started a grant to start a program in every hospital that has an emergency department in DC to have peer recovery coaches. And what does this mean? This means an individual who has lived experience personally with opioid use disorder, who would be employed to work in our hospital and to meet patients and be a source of support, converse with them, talk to them about options, tell them what worked for them, et cetera. So we were fortunate, Mr. Larry Gordine, who works at Psychiatric Institute of Washington, was able to partner with our hospital and start our peer recovery coach program. We have 2 peer recovery coaches, Mark Servatius, who is here today, and I'm so appreciative of his partnership and coming here, and Samuel Hairston as well. I will note that our peer recovery coach program has some huge wins. So in the last year, of all of the patients in our emergency department who were asked the question by our nurses, have you used drugs or do you use drugs, and also screened for risky alcohol use, 51% of them actually were seen by our peer recovery coaches, which is great, especially considering they don't work overnight and on weekend hours. So they've really added a lot, but when we did review the data, what didn't really change much for us, especially in their first year of having peer recovery coaches, was actual prescription of medications. So we continued, despite having a full year of peer recovery coaches with our patients, we had 0 prescriptions written in our hospital for buprenorphine for patients. So what other initiatives, did we try? So then we moved on to the sort of physician champion model. And, in addition to myself and Dr. Raman, we were really fortunate. We sort of looked across the medical enterprise to say, who else knows anything about opioid use disorder and is interested in this. And we found some amazing partners. I will call out especially in Keith Boniface and Karen Chung in the emergency department, in Farnas Farhi in OBGYN, as well as in Adam Greenwood in anesthesia, who were all interested and were just sort of lone champions in their departments as we were in ours. And so we had a lot of great conversations about how could we just think about the barriers in our own department and educating people in our own department. And then we felt ready to reach out to other champions throughout the hospital. So connecting with our nurse leadership, Elżbieta Kmecik has been amazing in letting us educate the nurses, connecting with our case managers, including Kristen Herring and her crew. And I will say, our most wonderful surprise was when we connected with the pharmacists, led by Lori Nizekwi. And we left that meeting and said, oh my goodness, the physicians are really uneducated and we don't know what to do. But the pharmacists said, we've been waiting for the day when someone would finally come talk to us because you want to prescribe buprenorphine. We've known about it for 20 years. So they've just been incredible partners to us in trying to improve the use of this around our medical center. And that just in every way led to provider education. So as Dr. Bass said, Dr. Raman and I have done, I think, countless talks, whether they be for medical students, for residents across all of the different fields, for our physician assistants, for our case managers, for our nurses, et cetera, just to get people talking about it and feeling more comfortable. So I will point out, though, with those sorts of interventions, how did we do? So over an 8-month period, when we looked at the data to see how many patients got an order for buprenorphine in our hospital, it was 16. Right? So, we went from 12 in 4 years from that choice study to 16 in 8 months. Okay, we're moving up, but we're still not nearly, as high as we can go. So we did some brainstorming and we thought, well, what is the next barrier? And we realized that our providers they hadn't learned before how to use these medications. And again, given the history of the X waiver, they were really scared to start doing that and just needed someone to talk through it. So we decided to start the OUD support line. And this was actually started by Manny Cabrera, who was one of our prior hospitalists who since left the institution, and myself. Luckily for me, right after he left, Dr. Raman joined, so I was never alone and had someone else on. But really all this is, we did a soft launch where we entered into our pager system the name OUD support. And we said, I wonder whole pages, and what they'll ask. And I will say it's been a year and a half that we've had this. We have received calls, about 93 different patients in the hospital. They've been calls from everyone. So we have had calls from medical students, from residents, from physician assistants, from attendings, from case managers, from pharmacy to confirm doses. So people have really, it's really illustrated to us that people just want help and just want to talk about it. So, I can't give any true attribution of any of these many interventions that we've had and how they've done, but in the last year, since having this pager system available, we've now had 77 patients who are admitted to our hospital who've had buprenorphine's orders written for them. And I really think that is a combination of all of these interventions going on, which is great. Thank you. Thank you. I do also want to give a shout out specifically to the emergency department of our hospital. They have sometimes called the support line, but I'd be lying if I said it was all the support line for them. They're really, I think that Keith Boniface, Karen Chung, and actually now their newest person, Erica Valdovinos, have really taken this on. And actually in the last year, they have averaged 10 prescriptions per month for patients who are in the emergency department and not admitted to our hospital. So we've really improved that quite a bit, which has been great. So, what are our next steps? So our kind of first step is to think about how do we codify this? How do we make it so that the easy thing to do is also the right thing to do, right, when you're practicing in our hospital? And so one part of that is just thinking about policy and protocols. And I know a lot of people hear the word policy and roll their eyes and think that's the boring part. But it's really important, to be able to say, what is our policy when someone comes in with opioid use disorder? Will we screen everyone? Will we offer to provide medication? Will we continue their medication if they're already on that? So that is all stipulated in our policy, which was just officially approved last month for the hospital. But those of you who go on the hospital's website and pull up the policy will see that all of the people who work together in our unofficial task force to craft that policy realized, okay, we can have a 2-page policy, but what we really need is the next 10 pages of protocol to tell people how to actually execute this and how to actually order these medications, which we've done. And really the most exciting next step is, well, how can we leverage the electronic health record to sort of include that protocol and to make it even easier for people to care for patients in the right way? So very excitingly, Dr. Raman, as you heard in the introduction, has received a grant from GW's Center for Population Health and Health Equity, run by Dr. LaQuandra Nesbitt, to help to actually leverage that in the EHR, get the clinical practice guideline in so people can follow that, and to roll it out in the future at Cedar Hill Regional Medical Center when that opens over in Ward 8. So we're really excited about that. I have to say, personally, as a primary care physician, to me, things that we do in the hospital are only as important as our ability to take them out of the hospital with the patient when they leave. So another area we have focused on is really about transitions out of the hospital, right? So one area to think about is how do we and how have we strengthened relationships with the already existing resources in our community? So DC, we are lucky. Our DC Health has done a lot to prioritize the treatment of opioid use disorder, and we have a lot of resources in the community, a lot of community organizations that are actually offering medications for opioid use disorder. So it's been really fun for us in the last 2 years to meet partners all throughout the city. I highlighted just a few on this slide who we've worked with, but HIPS, if you are not familiar with their work and their mission, I highly recommend that you read about them. I think they're just such an impressive organization. They are not at all medical. They are a community organization, and they realized that what their community needed was medications for opioid use disorder. So they actually started hiring first physicians, actually some of us, and then a nurse practitioner to actually deliver care on site there to their clients. And during COVID, when the rest of us who are medical were so busy being disrupted by COVID, they were actually the only site that was starting people on medications for opioid use disorders throughout the pandemic. Another important community partner that we've been working with to work on transitions are the methadone opioid treatment programs in town. So DC has 3 different methadone OTPs, and it has been so refreshing for us to reach out to them and say, hey, we want to start people on methadone in the hospital. How can we best link to you? And we've come up with a super low-tech method of fax cover sheets to just remind people what's the information that they need so that we can send that and make those transitions work. But they've been great partners and really interested in doing that with us. And then secondly, we can't only partner outside of our medical center, but how do we build capacity within our medical center to offer outpatient care for this? And so one great way, Dr. Raman has been doing this in her own primary care clinic, as well as with our residents in primary care clinic, and starting to have the residents feel like this is, in fact, part of the role of a primary care physician to be providing care in this way. So as I said, DC Health has been doing a lot. That's really impressive. We have a great landscape here in DC for medications for opioid use disorder, and we have more work to do to engage people in that. But there are at least 3,260 people who are receiving medications for opioid use disorder in DC. We have a program called My Rides, which can provide transportation to get to appointments for your medications for opioid use disorder. And in total, there are treatment providers that are actually available in every ward of this city and with 33 different community-based agencies who are providing them. So we do have places that we can link if we start people here in our hospital on this care. So what is next for us in terms of future directions and things we are excited about? Our next step in research is called the Choice STAR study. So this is also an NIH-funded study. I am a co-PI along with Dr. Irene Coe from the School of Public Health. This is with the same group that worked on the Choice study that I mentioned previously. So it is 4 institutions led by University of Maryland, ourselves, West Virginia University, and Emory University with Grady Hospital. And instead of being just observational and chart review like last time, this is actually a randomized control trial. And we're looking at discharge interventions that will help to prevent people from needing to come back to the hospital. So it's still patients who are hospitalized for infections due to injection opioid use, and what can we do to make sure that they are both getting treatment for their infection and for their opioid use disorder to try and decrease their need to be readmitted back to the hospital. So there are 3 arms of the study. 1 is the control arm, so 2 are the exciting arms there. 1 is intensive patient navigation. So this is using a model that's already been studied with a patient navigator as well as a social worker to really sort of walk alongside patients and help them to connect with the resources that they need that some of us may never even think about. So for example, you can't check into a medical appointment unless you have a photo ID. And many patients do not have a photo ID. So how can we help them to just obtain a photo ID and things like transportation to appointments, et cetera. The second interventional arm of the study is an integrated clinic that would combine infectious disease physicians as well as physicians who are treating opioid use disorder with medications. I'm really excited about this. This is the arm of the study that Dr. Raman and I get to participate directly in, and this will be working with Dr. Alex Semenyuk and Dr. Marielena Rees from the Infectious Disease Division here, as well as us, and saying, hey, when you come here, you're going to both see a physician who has expertise in treating your infection and someone who's going to talk to you about your opioid use disorder and can offer you medications for that. So we will see. We are to be enrolling soon once we get our official social worker hired. So if you know a social worker who might want to participate in this study, send them my way. But we are very excited to do it. So we really wanted to end today with the reason we do this work. And the reason that all of us here care about this and decided to come at 5 p.m. to hear a talk about this, and that's the voice of the patient. So the patient that you will hear speaking here is actually a patient of Dr. Raman's, who's been receiving medications for opioid use disorder with her for the last 2 months. And she expressed to Dr. Raman that she really wanted to share her story and really wanted to be able to use her experience to help others. She didn't feel ready to use her face, and she is afraid of public speaking, but was really excited about the thought that she could be recorded and share her experience with us. So with that, I'm going to let you hear her words, and I've asked her some questions that you'll hear as a sort of interview setting when she speaks.
Okay. So can you tell me about how you started using opioids?
Sure. I had given birth to my third daughter here at GW, cesarean. And they gave me some oxycodone after for the pain. And after getting it, a couple minutes later, I was like, wow, that felt really good. Like, I need to find out where I can get that. You know what I mean? Even after I give birth to her, because I know that been in the hospital, I'll be able to get it. But once I leave, where would I be able to get it? So that's how it started, and it was almost 16 years ago. She just turned 16 on the 6th of November. So that's how I started using opioids.
And so you mentioned that you had started 16 years ago.
Yep.
When did you realize you needed help, and was there something or what made you realize that?
Okay, so I had gone on a trip to my oldest daughter's graduation, and I knew that being back home, whenever I felt the need to use, I could just use. But I was miles away. I'm a Washingtonian. The graduation was in Wisconsin, and I did not like that feeling. Like, I was there. This is a big moment. My first daughter is graduating college. I should be focused on being happy, with celebrating her graduating. But my mind was worried about, oh man, I'm not going to be able to, get that feeling that I get when I use opioids. And I was like, no. So it took me a couple months though, but that mentally was where I was like, no, I don't like that. Anything having a hold on me like that, I didn't like. And so that's when I knew that, hold on, this is a problem. This is a very serious problem.
So before your current treatment, did you ever discuss your use with a doctor? And if not, were there reasons why you didn't?
Sure. No, I've never discussed it with the doctor, simply because there are rumors out there that if you tell people about your addiction, or doctors about your addiction, if you were to get hurt or have to have a surgery, that you wouldn't be able to have pain pills or be prescribed pain pills anymore. So that's why I never discussed it with the doctor before now.
How has starting treatment for opioid use disorder impacted your life?
Oh man, I can't say enough about Dr. Raman and the staff here at GW. It's been wonderful. It has helped me get back to my normal life. I'm not having to get up and worry about where my next pain pill is going to come from. It's helped me be more into my girls' lives. It's given me more energy starting my treatment here. Dr. Raman was so patient with me. She was really patient and she cared. You know, she'd check on me, she'd call. So I'm very, very appreciative of her and starting my journey with getting sober, clean.
So I feel like she just gave a summary of our whole talk, in those 4 minutes. But I hope that was as special for you to hear as it certainly was for me in performing that interview. So I do want to leave us with, there is hope, right? There's hope on the horizon. I think that particular patient would say she feels hopeful for what's to come. And this is actually the most recent data from the DC Office of the Medical Examiner. And this is only half the year that's in so far. So this is through June 30th of 2024. But if our overdose deaths continue at the same rate that they did in the first half of the year, we are actually on track that this may be the first year since 2018 that our overdose deaths in DC may be decreasing rather than increasing. So, I encourage everyone to leave feeling hopeful about this and sort of how we can take this and what we can do next. And as I mentioned, sort of in speaking about our approaches here, I just want to acknowledge that this has really been such an incredible team effort, and it has been such a privilege. I know I speak for Dr. Raman and myself to get to meet so many people across our medical center and hear how many people across this city, as well as across this medical center, really want to work on this problem and are willing to partner for innovative solutions and ways to do that. I do want to say in particular, because I did highlight the DC Hospital Association here, I mentioned them with the Peer Recovery Coach grants. They actually have just come up with a potential protocol that people can use in their hospital if they haven't started their own protocol for medications for opioid use disorder. So I was thrilled to see it looks very much like our protocol, but is available. And I think there's just so much that can be done when we partner across town and across institutions so that we don't all reinvent the wheel, but actually share our work together for the patients that we're trying to serve. So thank you all very much. We're going to be taking questions along with Dean Bass. And I do want to point out, when we are finished, as you leave here on your way to the reception that is upstairs, we have a wonderful student group here. So it's Harm Reduction to End Overdose. And they are in the back at a table, and they have naloxone or Narcan medication in case anyone feels like you would be willing to reverse an overdose were you to witness one in a loved one or in a stranger. They're there, and they're willing to give out any free Narcan to anyone who's interested in having that. They'll also be up in the reception area, too, for us as well. So thank you.
Well, thank you very much for that, those really impactful and meaningful and powerful presentations, that blend of incredible humanity first and, kind of getting back to that basic thing of what we do as doctors to try to keep people well and take care of each other. But the challenges of this particular one and finding that little magic moment where maybe you can take that first step and creating a system around that, that's fabulous. It's just really exciting. And to have a group of students and others and residents and other faculty that you're bringing along with you on that ride is just great. So thank you for that. Questions? Yes, Dr. Siegel.
First of all, thank you for that excellent talk. You should do it either way. Thank you for that excellent talk and everything you've done to help address the opioid epidemic at GW. Two questions. So I have limited number of patients I prescribe Suboxone for. Two things. A couple times they tell me not every pharmacy has Suboxone, and so they often have to go to multiple pharmacies. And then they generally want brand name versus generic, and I'm not really sure, is there a difference, and why would that be?
I can take that. Yeah, sure. You and your patients are right in that not all pharmacies, unfortunately, carry buprenorphine. They should, but they don't all carry it. And there are lots of reasons why that might be. And there have been a lot of efforts, regulatory efforts, in DC and more nationally to try to get pharmacies to be carrying buprenorphine. Of course, there are multiple different products. We didn't really go into all the different formulations in which it's available. So my experience has more been that most pharmacies now actually do carry buprenorphine. They just might not have the exact dose or the exact product that you need. I will say that for those of you that work at GW, our pharmacy, GW MFA pharmacy, really carries like almost all of the formulations, most of the doses. They have them in stock and have found them to be a really useful resource for our patients. Sometimes patients do describe this difference between brand and generic. It doesn't physiologically make a lot of sense, but if that is the case, I just try to stick to one. But I actually haven't really had that experience a lot recently. I have sometimes in the past, but not a lot of late.
I have a question. So if you have this acute moment during hospitalization when you get someone started on this medication, when they go home, though, I mean, that transition point, how important is the additional measures around them? You know, not just the medication, but other types of therapy support, community engagement. What's the balance and what's the total special sauce that's required here?
So I first of all really appreciate that you phrase it as like all of the components of the engagement around. So when that X waiver used to exist, remember, it no longer exists. When that used to exist, one component was that you actually had to attest that you could and would refer patients to mental health support when prescribing. And that has also gone away. And the reason why is because the data on did that truly add to the care, so meaning either or really both keeping people engaged in care as well as keeping people opioid free, showed that it actually didn't. Now that said, there are many other things that mental health support is helpful for. And so I think the right approach, and I think most people who've been practicing in this area, I think the right approach is certainly to still recommend that people engage with mental health support because there are a lot of comorbidities. So it is very common for people to have mental illness who also have opioid use disorder, to be victims of trauma and perhaps of PTSD and also have opioid use disorder, or to use other substances that I'm not treating with this medication for opioid use disorder. So there's certainly a role for that. I think you also highlighted the role for what all the other parts of the environment mean and all the other parts of support mean. So that is a hard moment. When we have you in the hospital, you're sort of captive there. We've changed your environment entirely. You're not seeing the people who you used to see who are using opioids. You're not having to walk past the person you typically purchase them from, et cetera. So it is a very hard kind of reimmersion in that. And you know, we unfortunately can't be there, can't walk alongside them to do that. Our hope in the future is that we can actually get a broader, larger grant for our peer recovery coaches, because what I know Mr. Gordine is hoping to do is have a coach who can actually meet patients after the hospitalization and give them that support as a warm handoff, which would be really helpful. So the best that we have been able to do is try and give people pretty quick follow-up so we can see them soon afterwards, give them a phone call, check in on them, but it is hard to go back into the environment.
I just want to add to that the point about, you know, the hospital system or situation is different than the environment at home. I think that is even more important to recognize when we think about rehab, which is kind of what we in in the media and among non-physicians and among physicians as well, we really think about when you think about someone that has an addiction, right? Oh, well, they need to go to rehab. And the data about residential rehab for substance use disorder is also really not great because that's a lot of what's happening, right? You're taking someone out of really the circumstances that they live in, and then when they go back and re-engage, especially if they're not receiving medications, they really, the relapse rates can be pretty high, and their tolerance for the opioid drops, and then if they are to go back to using the same amount, they have a higher risk of having an overdose. So I think that context is important to think about.
Yeah, very important. Question? Yes, there we go.
Thanks. Fantastic work and great collective talks. Thank you both. I'm a native Washingtonian, just came back, joined the faculty, last month. When I was a kid and when I was a young physician here, crack was still the thing. and people got crack because they could get crack. Opiates and opioid use disorder seems to be a us-created problem. So my question to you, and specifically talking about your future work and your research that's funded, is there any upstream conversation? Are we talking about how do we as clinicians, stop your patient's journey to opioid use disorder at the beginning? Certainly as a surgeon, we've done a better job, I think, collectively across the country, but I'm wondering if your work is also looking upstream to see if we can start the process before it starts. Thanks.
I guess we'll both sort of speak to it. So first of all, I think you're absolutely right, and I'm forgetting now the last data that I saw, but is it a third of people who have opioid use disorder who say they started with a prescription? It's roughly that. It's roughly that. And I think our patient who was interviewed was a perfect example of that, right? That started with us and with our own prescription pads, right? I will say that it's not in our general work in terms of a project that we're working on, but I will say that importantly, when we started doing education of the surgery residents, they asked this right away. And we brought up the current CDC recommendations for, how many days of opioids should you expect to give someone after a surgery, and how quickly should they transition to other medications, and what are those other medications? So I was really encouraged to see that the residents were really thinking about that. They definitely had some examples where they thought that perhaps people were a little too liberal with opioids, and I think we've all seen that across the medical center and across our practice, where you'll see someone and think, oh, I wish someone hadn't given you, what they'd given you, and it's hard to figure out how to go back and stop that, besides having honest conversations as colleagues. So when we see people in that scenario, I recently saw a patient who I sort of suspected maybe myself and that patient were having different conversations than they were having with the person who was their prescriber. And so I did reach out to that prescriber and have a conversation about that. And I think some of that one-on-one talking is probably a low-level but effective way to do that.
Yeah, and Jill and I, as you can tell, are wearing a lot of hats and doing a lot of different things, and we don't necessarily get all of the time every week to catch up on the different initiatives that we're both starting. So one thing that I haven't told you yet, and I'm going to tell all of you, is that as part of the curriculum for the internal medicine residents, the addiction curriculum that I'm designing, I've actually added an entire module on prescribing, so opioid prescribing for pain. So that's not directly treating addiction, but it's how to prescribe well and safely and in a way that you're less likely to lead to dependence.
Yeah, I think it is important to note the opioid sparing strategies that have been really widely developed and implemented in a very intentional way in elective surgery across the country. And I really give kudos to the folks that developed those ERAS protocols, and particularly the opioid state. That's made a big difference in how we train our residents in opioid use for our student patients. Yes.
Hi, thank you so much for your excellent talk. Building on from that point in terms of harm reduction, in terms of prevention, even after someone may become addicted or a user, in terms of implementations like safe use sites, what does the future look like for maybe things like that?
Mm-hmm. Yeah. Do you want to take? Sure, yeah. So I'm not sure how many
I didn't
of you...
plant her. We had a slide all about harm reduction and then thought we had to take it out, so thank you for asking.
We did remove it because we had a lot of slides and we wanted to keep it short. But so for those of you that are not familiar with safe injection sites, that is kind of what it sounds like. So it's a space for people to go and inject in a safe way. So in a place where there are peers, there are healthcare providers there. If they need to be there, there are resources. So clean needles, Narcan, to reverse overdoses, et cetera. And that we consider to be a form of harm reduction. So harm reduction is a social justice movement that is a part of substance use disorder treatment. It's really the idea there is to minimize consequences, harmful consequences of drug use, right? So abstinence is not a prerequisite to reducing negative consequences from use. We have as a society and as a country, been behind, I would say specifically as it relates to safe injection sites. Canada, Toronto especially, where, and Vancouver, where the opioid epidemic has really sort of raged. They have a couple of legal safe injection sites, and then the first one in the US in the Bronx in New York actually opened, I want to say now a year and a half ago, and the data has been overwhelmingly positive. So they've had, you know, the sort of argument against things like that, against harm reduction practices is like the sort of classic, you're going to increase use, right? You're going to make people want to use more, and that hasn't been what they've seen. They've actually had 0 overdoses or fatal overdoses, and I think if they have had any, those have been reversed, and it's been it seemed to be really positive. So I'm hopeful that that is a direction that we can move in. I will stop there.
Hey, well, okay, one last question, Dr. Fagan.
Really super encouraging, you know, what you guys have seen with just this one, you know, small-ish intervention when you look at the consequences of opioid across the city. In thinking about the patients who, you know, are on therapy, especially those who are discharged, what is the access like for them in the community in terms of folks that are uninsured? You know, how expensive is this therapy outside, you know, of our usual payer situations? Like Medicaid, does it cover it? Medicare, you know, Part D, or, you know, for uninsured patients, are there opportunities for them to get treatment without cost?
Yeah, thank you so much for asking that. So first, I am very excited to say we are lucky in DC. Every insurance that I can think of does cover buprenorphine. That is DC Medicaid, that is all 3 of the Medicaid MCOs that are here, that is every commercial insurer that I know as well. So we can get this covered for patients. Sometimes there's a question, as was alluded to earlier, of a particular formulation. So it comes in a dissolvable strip, it comes in a pill, and if you prefer the pill, maybe your insurance prefers the strip. And I've actually had pretty good luck with asking for the other, if they cover one of those. But we also are lucky in DC, so we have a program called BUPDAP, and so this is modeled on the Ryan White ADAP, so AIDS Drug Assistance Program for people who do not have insurance. DC has a structure, if you live in DC, so have a DC address, if you don't have insurance, you can actually obtain buprenorphine through BUPDAP to get that, and there's one central pharmacy that dispenses that.
Well, thank you. I want to thank you for shining a light on this incredibly still deadly problem and your great interventions, modeling our wonderful programs in applied clinical public health practice, but also for your work and your dedication to this. And thank you for sharing it with our community today. Appreciate it very much.